What's up, y'all? Welcome back to From the Ground Up. Today, we are getting into the ribcage. We're going to talk about the ribcage being king, especially as it relates to pelvic floor dysfunction. And I'm so excited because this is my whole top-down perspective, okay? This is treating the pelvic floor from the top down now. And this is one of the concepts that has changed the game for me and how I treat pelvic floor dysfunction. I believe that giving our patients, quote unquote, pressure management exercises that are centered around the pelvic floor and the lower abs is actually missing the whole point. Instead of managing the pressures, let's actually change, displace, and decrease them so our patients don't even have to worry about managing the pressure. Pressure management should go way beyond training the pelvic floor muscles to simply fight against the pressure, all right? Because that's what traditional pressure management exercises are, aren't they? Supine exercises, picture like bridges, or let's elevate the pelvis to offload it, or let's cue a pelvic floor contraction like a Kegel during times when the patient experiences pressure symptoms like leaking or heaviness or prolapse, right? So traditional pressure management basically treats pressure problems from the bottom of the pelvis up. And all this is doing is training the pelvic floor muscles to fight against that pressure coming down on it, okay? And where I want to challenge you and invite you to think differently and think better is instead of training the pelvic floor to fight this pressure that's just coming down on it from the top and just kind of like, let me just like grip and get stronger and like fight against this pressure, right? I want to encourage you to think about how we can actually change the pressure, how we can move it, how we can displace it and even decrease the pressure. And I'm going to explain how to do that today. But I wanted to talk about this traditional pressure management because that's what all of us are taught. We're taught if someone has prolapse to give them bridges because it elevates the pelvis, which offloads it, and it strengthens the glutes, quote unquote, which is supposed to help the pelvic floor, right? That's everything that we're taught. Icing on the cake, squeeze the pelvic floor when you give a bridge, right? That's literally like what we're taught in like pelvic floor 101 to treat prolapse and people with pressure problems, okay? All that is doing though, whenever we look at pressure management exercises, if you're watching this, I put it in quotes because I hate managing symptoms. So why do we want to manage pressure? Okay, we want to change it. We want to get it the heck out of there. We want to fix it. So I literally hate from the get-go calling something pressure management exercises because if you're giving a pressure management exercise, you're not giving them something that's going to fix it. You're giving them something that's going to be a Band-Aid and that's going to manage it. Okay. Side note, if we're doing traditional pressure management exercises, like training the pelvic floor or teaching the pelvic floor to squeeze against this downward pressure to fight against it, okay, you're actually going to perpetuate things like pelvic floor tension and descension of the pelvic floor, and you're going to perpetuate their pelvic floor symptoms. I want to give you an example when we think of pressure and prolapse and leaking that has been really helpful for me. If you picture a tube of toothpaste, okay, and we unscrew the lid and the opening to the tube of toothpaste is facing down. And then I'm going to squeeze the tube of toothpaste in the middle of the tube. And that creates pressure and it pushes it down. And because there's no lid on the tube of toothpaste is just going to come out, which is what we want when we're brushing our teeth, right? We're going to just take that toothpaste and we're going to put it on a toothbrush and we're going to brush our teeth. And everything's great with the world. But if we think of the tube of toothpaste as our patient's core, and where the lid is, that is their pelvic floor, okay? And then the squeeze on the middle of the tube of toothpaste is really anything that's causing pressure. It's a rib cage that's not expanding. Could be tight pants. It could be tight pants, frankly. It's upper abdominals that are gripping and that they're, kind of staying squeezed and concentrically oriented at the top of the abdominal canister. Anything like that we can imagine is putting that kind of midline tension on the middle of the tube of toothpaste or the middle of our core canister, okay? All of those things are directing that toothpaste, that pressure downward to the hole, which in this example is our pelvic floor, alrighty? So traditional pelvic floor exercises say, to keep the toothpaste in, aka keep us from leaking, keep our bladder from falling out of our bodies, like all the things, right? Traditional pressure management exercises are going to tell us to just screw the lid back on the tube of toothpaste. Just keep it in. Just keep in the toothpaste, just keep in the pee, keep in the bladder, just hold it tight. The reality is, though, is that the harder you squeeze, whether the lid's on or off, the harder you squeeze, the more pressure is going to come down. And if the lid's on, it'll hold the toothpaste in for some amount of time, but you could ultimately squeeze that toothpaste hard enough to where it'll blow off and then it doesn't matter anyway, right? So traditional pressure management exercises are telling us to put the lid on the tube of toothpaste. They're essentially saying just close off the bottom where the symptoms are happening, where the leaking is happening, where the prolapse is happening. Just make it tighter. Just close it. That is traditional things like bridges with a pelvic floor squeeze. That's traditional things like, just elevate the pelvis and the toothpaste will just, slink back up, right? Well, I'm sorry. What happens when our patient gets up off the floor and walks and lives their life? They're not going to have their pelvis elevated, okay? This is where I want you to challenge to rethink pressure management exercises. And I want to encourage you that we need to go beyond management of pressure symptoms. Let's not just put the lid back on the tube of toothpaste, okay? Let's actually expand the tube of toothpaste in the middle where all that squeezing is happening and create more space, more expansion in the tube of toothpaste where that toothpaste can expand up and out into, so that way there's less toothpaste pushing down on the open hole. Even if we didn't have a lid, if we took the lid off the tube of toothpaste, and if we only fixed or we only expanded that part that was being squeezed and we somehow were able to blow air in there, I don't even know how we would do that on an actual tube of toothpaste, but it doesn't matter. For illustrative purposes, y'all, if we could expand that tube of toothpaste in the middle and create space there, even if we took the lid off the tube of toothpaste, now the toothpaste is not threatening to come out. It's not being pushed down. It's not being squeezed out, okay? It has room to go. It has room to displace elsewhere and to expand into that part of the tube that was once crushed, okay? This is how I want you guys to think about pressure and treating pressure problems in our patients. Let's stop settling for managing the pressure, aka putting the lid on the tube of toothpaste and just hoping it holds it in. And let's actually figure out how to expand the tube of toothpaste. So that way, whether we had the lid on or not, whether our pelvic floor is prepared or not, right? The toothpaste is going to stay in. Our patients are going to not leak. Our patients are going to not struggle with feeling like their bladder is falling out. Our patients are not going to struggle with all of this pressure and heaviness that they're feeling, okay? When it comes to pressure symptoms, so leaking, prolapse, heaviness, kind of that achiness that our patients might complain of, I believe that it all starts up in the area of the rib cage. It all starts from the top coming down. It's less of your pelvic floor is weak, so you're having all these like symptoms, and it's more of, for some reason, pressure is coming from the top down, and whether your pelvic floor is weak or tight isn't going to matter if there's so much pressure coming down, okay? I believe it all starts in the rib cage when we're talking about pressure symptoms. And I believe that we can actually work in our patients' bodies to change this pressure coming down onto the pelvic floor rather than teaching our patients to simply manage that pressure, okay? So I was going to say a math formula. Is it math? Is it physics? Is it biomechanics? I don't know. But I have a formula for you guys, for you math brains. And it actually was really helpful to me, which I am not a math brain. So maybe this will be helpful for everyone, hopefully. A formula for you guys to picture. And maybe if you're listening, you just write it down because this is going to be really helpful. That is going to help you reframe how you think about pressure and when it comes to managing it or changing it, which I'm encouraging you guys to learn to do. And the formula is this. It's pressure equals force over area. Okay. Like I didn't make that up. That's like a real physics formula that I didn't remember off the top of my head. But years ago, when I was trying to learn more about how to treat pressure in my patients, I looked up, what is pressure? And it showed me that formula. And I was like, that makes all the sense. And I'm going to explain it to you why it makes sense. So if we look at this formula, pressure equals force over area. What this means is it's this relationship between force and area. Okay, so if force is on top of area in the formula, the larger the force or the smaller the area, the more the pressure. That's how fractions work. Okay, don't ask me. I'm not the mathematician. That's just how they work. So the larger the force or the smaller the area on that relationship of that fraction, the greater the pressure on the other side of the equation, on the other side of the equal sign. Alrighty, so knowing that pressure is impacted by the amount of force and the size of the area, we have two options to change the pressure. Okay, remember, we're not managing anymore. We're going to do better. We're going to change it. So we have two options. So we can either decrease the amount of force coming down, okay, or we can increase the area that the amount of force is coming down onto. Either of those options or a combination of those two are going to decrease pressure, okay? And I'm going to explain what this looks like for your pelvic floor patients. Let's talk about first decreasing the amount of force coming down. Traditionally, in order to decrease the force coming down on the pelvic floor, we might have told our patients, lift lighter weights. All right, if we pick up a lighter dumbbell or a lighter barbell or put less plates on it, okay, technically that is going to decrease the amount of force. All right, that's some traditional advice. Just decrease the amount of weights you lift if you have prolapse and you'll be fine. Like, it's fine, because women don't want to get strong, right? Because we're just these dainty things. And like, oh, if our bladder's going to fall out, too bad. I guess you just won't lift weights and get strong. And in that case, you're just going to have osteoporosis and die an early death. Fun. It matters. It matters for the long term of women's health, okay? So traditionally, we've been told lift lighter weights to decrease the force. Or we've been told avoid the offending activity, right? If I leak when I jump rope and I avoid jumping rope, well, I've decreased the force that comes down on my pelvic floor so I don't leak. Is that our goal? Do we want people to stop doing these activities that they love and that are helping them get healthy and, build strength and cardiovascular health and all these things? I'm pretty sure every one of you is shaking your head. No, that's not our goal. But that's some of the traditional advice that we've gotten to decrease the force, is to just avoid the activity that is causing symptoms. Okay. Then there's also a similar one, modify the activity. Alrighty. Oh, if, you leak or you feel like your bladder's going to fall out whenever you do a sumo deadlift, well, maybe let's try a traditional deadlift, or let's try a different kind of deadlift, an RDL. I don't know. There is a time and place for modifications. I'm not saying that we should never modify. What I am saying, though, is if modifying an activity is your solution, like your final solution for your patients to not leak whenever they do a deadlift, and they're telling you, yeah, but I compete in powerlifting and sumo deadlift is one of the moves, or whatever, right? That's not going to work for them, okay? There's 100 examples that I could go into of like what we might be telling our patients to modify to decrease their symptoms, and they're going to like look at you and be like, you didn't help me at all, because I told you my goal was X, Y, and Z, and you modified my movement or modified what I was doing and called it good, because when in the modified movement, I don't leak. They're going to just think that that was crappy. And frankly, it is crappy. Okay. So traditionally, when we're talking about decreasing force on the pelvic floor in order to decrease pressure, we hear things like lift lighter weights, avoid the offending activity, or modify the movement forever, by the way, because people aren't thinking how to get them back to the offending activity. And that's traditionally what we have been taught for pelvic floor, to decrease the amount of force coming down onto the pelvic floor. Okay. Instead of telling people to lift lighter weights, avoid activity, modify activity for the rest of time, if we keep the total amount of force the same, AKA we haven't changed the amount of weight they're lifting, they're doing the same offending activity, we didn't have to modify it, so the total amount of force is the same, okay, we can displace that force. We can move it somewhere else. It can stay the same total force. Total force can stay the same. We didn't decrease weight. We're not modifying the activity. We're not avoiding the activity. The force is there. So we can actually move the force elsewhere, which is going to decrease the pressure on that area. So let's talk about some ways that we can actually move that total force somewhere else. So I think of things like ribcage expansion, right? I said this pressure stuff, in my opinion, always starts at the ribcage. Ribcage expansion, this is expanding the tube of toothpaste in that example I gave you, is if we expand it, it is going to create more space inside the canister, if you will, for the force to be able to displace and move and spread. So that way it's not all coming down on one area. Okay. So that's one way that we can kind of modify the force. Okay. Not the movement, but modify the force. We just have it move. And things like ribcage expansion could be really, really helpful. This is allowing the same amount of total force, like I said, but it's not all going down to the same area of the pelvic floor because we created space for the force to move to. So we didn't decrease the force necessarily in the formula by saying lift lighter weights, but what we did do is we moved the same amount of force and we gave it more space to go into. And so it's going to end up having less pressure onto the pelvic floor and less symptoms. So some examples of my favorite posterior rib cage expansion exercises. I really like some stuff in quadruped. I really like, an example could be there in quadruped. I tend to cue them to kind of push their hands into the floor and think about lengthening through their thoracic spine, kind of that mid upper back area up to the ceiling, and using really the serratus anterior muscles to get that push and to pull those scapula kind of around, which, by the way, not only does the serratus anterior pull the scapula around, it also lifts the rib cage because of the muscular attachments. It lifts the rib cage posteriorly. So what we're going to do, if we're just in quadruped and we push into the ground using the serratus, we are going to lift the rib cage posteriorly and create space back there for expansion and for pressure to move into and for force to move into. So that's like one example of a favorite ribcage expansion exercise. Sometimes you're going to have to look at the ISA, the infrasternal angle in the front. You know, we have norms for it. I think it's like 90 degrees to 110 degrees. Somewhere in there is like quote unquote normal. I actually just want it to move. Like, I actually just want our patient's ISA to be able to widen and get more narrow, and widen and get more narrow. Yes, when they breathe, but also when they're doing functional movement. So like that might be one place you want to look too, is your patient's ISA more on the narrow side? And if it is, doing some stuff to kind of expand the ISA on the front, using internal obliques, which are going to attach right there, and their angle of pull is actually going to widen the ISA. Ultimately, how can I create more expansion at the rib cage so that way the force has more space to move into, so that way your patient doesn't have to avoid the activity or decrease weight? So that's one part of that formula, is changing the force. So decreasing the amount of force that's coming down. The other part of the formula is the area. Okay. It's increasing the area that the force is coming down on. So this is the bottom part of the formula. If you picture it, you got pressure equals force over area. This is the bottom part of the formula. So naturally, the way that fractions work is if the bottom number gets bigger, then the total number is smaller. So pressure is going to be smaller. Okay. Math. It's fun. It's fun today. We're having math lessons. This means that the area that the force is coming down onto, aka the pelvic floor muscles, needs to be bigger. We need to increase the area of the pelvic floor muscles if we want to be able to decrease pressure without necessarily decreasing force. Alrighty, because remember, you only have to change either the force or the area, or you can change both. But if you just change one of them, if you decrease force or increase area, you're going to decrease pressure. So this one, we're just focusing on the area part. So in the pelvic floor, we want to create length, we want expansion, we want more space throughout the pelvic floor, but namely the posterior pelvic floor. So the back half of the pelvic floor is kind of what I'm talking about, what I'm picturing. And this is because most humans are biased to be in a little bit more anterior orientation of the pelvis. I'm going to go into this a lot more in detail in the next episode, actually, where I talk about the pelvis. Most of us are biased a little bit more into anterior orientation. What that's actually going to do is shorten the back of the pelvic floor. If we have a shorter, more descended pelvic floor, you can imagine the muscles being shorter. That is creating less area for the force that's coming down to go onto. And so if we think of the formula, we need to increase that area or expand the posterior pelvic floor muscles, expand that area. So that way there's a greater area for the force to go down onto, and that will decrease the pressure symptoms. Okay. It's math. I'm not the one making this up. Okay. It's literally a formula from physics or from math. Be thinking of a patient that you have maybe who has prolapse or they leak or whatever it is. And I want you to think about their posture and think about their pelvis. And you probably are picturing maybe they have just a super anterior tilt, okay? Or maybe it's less of like an anterior tilt with a lumbar lordosis, and maybe it's more of just the forward weight shift, like that everything is just like shifted forward. Both of those body types, which are very, very common, by the way, both of those body types are experiencing decreased expansion ability in the posterior pelvic floor. And so what that's doing is that's less area for the force to come down and be like absorbed into. And it's pushing our organs forward. It's pushing the bladder forward into the front of the pelvis, into the anterior pelvic floor. And then that's contributing to these prolapse symptoms, these leaking symptoms, things like that. And so be picturing these pelvises. And typically what we're going to see is the iliums are a little more externally rotated and anteriorly oriented. And then that kind of forward weight shift. And so some people don't end up getting that forward weight shift. Some people do. But either way, typically we're seeing these external rotated iliums with the slight anterior tilt. So just be picturing that as you think about your patients and as you hear me talking about this pressure stuff. By expanding the posterior pelvic floor, we can better orient the pelvis as a whole, which is going to make it work better. It's going to make the pelvic floor muscles work better. In order to do that, in order to create this pelvic floor expansion, we basically have to reverse the position of the pelvis that I just explained to you. So if I say most people are externally rotated and anteriorly oriented, maybe forward shifted, we got to do the opposite. We got to get them posteriorly shifted, get their weight back in space. We got to get their pelvis more neutralized, less anteriorly oriented, and we have to get those iliums the ability to internally rotate. Let me explain why this is going to help with the pressure symptoms. Because when you picture the iliums in the pelvis and the pelvic floor muscles where they attach to the outlet, we need the iliums to be able to go into internal rotation to widen the pelvic outlet. If the pelvic outlet is widened, if that space, that bony space gets greater, the pelvic floor muscles that attach there are going to lengthen. They're going to expand. So it all comes down to what are the pelvic bones doing? How can we get them less externally rotated, more internally rotated, which expands, especially the posterior pelvic floor muscles, increases, guess what? That area of the pelvic floor muscles. So now there is a greater area for the force to come down onto rather than it all being funneled anteriorly to the front part of the pelvic floor. If we can just fix kind of where the pelvis lives in space, which might mean we got to look at the foot and ankle. It probably means we have to look up the rib cage, all those good things. But if we can ultimately get that pelvis a little bit back in space, a little bit more posteriorly oriented, and get those iliums to freaking be able to internally rotate, your patients are going to stop leaking and they're going to not complain of prolapse symptoms, and they're going to literally be like, you fixed everything. And you're going to be like, oh my gosh, I know. We want to give the pelvic floor the ability to gain that expansion, to increase that area. So that way the amount of force that's coming down has a greater area to come down onto, and that will decrease the pressure. Pressure being leaking, prolapse, heaviness, pain, all of those symptoms that our patients complain of. One of my favorite exercise ideas for posterior pelvic floor expansion is actually picture, it's going to be in quadruped again. So picture a yoga block. You have your patient in quadruped. You put a yoga block underneath, let's say their right knee. All fours are on the ground, but their right knee is elevated slightly onto a yoga block. That act of elevating the right knee alone without doing anything else, that has actually caused on the right side, it has caused some adduction and internal rotation of the femur and thus the ilium, because they kind of follow each other and do what each other does. So just by giving us some adduction and shifting that femur into the posterior socket, really, that has created space already. Just by putting them in this position and not even doing anything else, that has already created some space in that right posterior pelvic floor. From here, sometimes I'm just like, breathe. This is where I give them butthole breathing. I'm like, breathe into your butthole, because I've now put them into this position of biasing that right posterior pelvic floor to be a little bit more lengthened. And now I'm going to take advantage of the pressure system that is breathing, and I'm just going to have them breathe. I'm going to have them breathe with their rib cage and their diaphragm in this position. And just that, the changes of the pressure gradient that happens when we breathe in general, coupled with the position that I put that right posterior pelvis in, is going to work wonders on lengthening the right posterior pelvic floor muscles. And then guess what? You just go and you switch the sides and you have them doing the left. And then you can add fancy things. You can add like a rock back, and you can add, like a hip shifting thing where it's almost like a mini hip airplane type of vibe on the block. But even if you just start with putting their one knee up on the block and having them breathe and like literally say, breathe into your butthole. And because you've biased that side to be more expanded, it's going to help with the expansion of that side. And then while you're there, why don't you throw in some little serratus pushes and some expansion of the posterior rib cage area, and then you have yourself a perfect little exercise for your pressure people. That's just an example of one of my favorite exercises. I have a ton more if you're interested in my course. The big takeaway that I want you guys to have today is, please, for the love of God, stop thinking of it as pressure management exercises. Let's stop managing things. Let's actually fix them. Instead of pressure management from the pelvic floor, let's think of it in terms of pressure change through displacement of force, right? So moving the force, creating space for it to go into up at the rib cage. That's expanding the tube of toothpaste, and increasing the area that the force is coming down onto. That's pelvic floor expansion. Okay. If we truly want to fix the root cause of the pressure symptoms in our patients, we have to change the pressure, not just fight against it with pelvic floor contractions and traditional pressure management techniques. The pressure stays the same. You're just teaching them to just squeeze against it and fight it for the rest of time. And that's just lame. That's lame. Training the pelvic floor to fight against or withstand the pressure only gets our patients into more tension and more pressure symptoms in the long run, you guys. The more you cue them, just squeeze your pelvic floor, just put the lid back on the tube of toothpaste. The more you give them stuff like that and you don't actually change the pressure, you're going to cause more tension symptoms and more pressure symptoms down the line, just simply because you didn't fix what was actually happening. Look at ways to gain ribcage expansion, okay? A lot of posterior expansion will help. I also want you guys looking at the ISA to see, is it dynamic or is it kind of stuck? Do we need to get it to be able to be wider? Do we need to get it to be more narrow? And look at ways to gain posterior pelvic floor expansion as well. And those two things, getting ribcage to expand and rotate and all the things, and getting the posterior pelvic floor to expand, those two things is like your magic ticket to be able to truly alter the pressure at the pelvic floor, because it's that magic formula, okay? You're just changing the fraction to change the pressure. If you guys found this helpful, I have an awesome free guide for you guys. It's called the Top Down Guide, and you can get it at the link in the show notes. And I'm going to explain everything that I just talked about, plus a little bit more about how the rib cage is impacting the pelvic floor muscles. So definitely check that out. And also, please join the waitlist for my No Kegels course. We are having our next cohort launching soon. I only do this twice a year. So if you're not on the waitlist already, click the link in the show notes and make sure you're on it. So that way you can learn my entire treatment framework when it comes to pelvic floor dysfunction and treating without Kegels. And you guys, my last ask is, if you found today helpful at all, I would love if you would screenshot this episode and share it to your stories and tag me, and that would just absolutely make my day. So thanks so much for being here. I love y'all, and I will see y'all next time.